Hi, Paul. This is Bridget. I'm back.
Hey, Bridget, I hear you loud and clear, friend. Hopefully the
Okay,
audience
great.
can hear you too. Thank you so
I hope
much.
so.
Okay, I think that everyone's dialing back in here, so I'm going to go ahead and start us over again with this Q&A segment here. I know you talked about this a little bit earlier, Bridget, but folks had some more questions just kind of about is most of the information we talked about also applicable to pregnant transgender men and non-binary folks? I mean, we tend to say pregnant women reflectively, right, when we deal with this topic, but I think folks were just looking for a little bit more clarification as far as applicability. Did you want to speak more to that?
Yeah, I would say it would definitely apply to pregnant transgender men and non-binary, because we're really looking at the impact on whoever is carrying and then the fetus and the infant at delivery.
Great, great. And I'm going to sort of pick a couple of these questions just as they come through randomly here, because I want to make sure we cover as many of them as possible. Folks had a lot of really good questions here today. Just scrolling through here, multitasking as we do this. So I really appreciate everyone's patience here as I pull these up.
I think there was one question about, oh, sorry, Paul. I was going to say there was one question about the lithium. And
yes.
the cardiac. Yes, yeah, absolutely. The risk of cardiac defects is very low. Epstein's anomaly is estimated between like 1 in 1,000 or 10 in 1,000. So although the risk increases with the dose, it's still very, very low. And usually, in most cases, continuing the medication is going to outweigh the risks of anything else. So
this was the question where somebody had said that they had thought there was like a 3-fold incidence of cardiac defects in doses greater than 900 milligrams a day. I think that's the one. Yeah. Okay.
Yep. But the risk is still relatively low. So yes, if the risk of relapse of psychiatric illness outweighs the risk of continuing lithium. So continue that lithium, do the 20-week anomaly scan, and go from there.
Cool. Excellent. Thank you so much. And then here's another one, dialing in on a couple other specifics. Are you able to tell us a little bit more about Seroquel and gabapentin safety in pregnancy?
Yeah, I'm not sure about gabapentin, but the Seroquel for most of the first-generation or second-generation antipsychotics, they seem to be relatively low risk in pregnancy. Some of the things that we're more concerned about is with quetiapine would be excess weight gain for the mother or whoever's carrying, and the other issue is there's some concern about blood glucose or high infant weight with quetiapine. But again, we still, even though they're common, we still have pretty limited data about their use in pregnancy.
Okay. More exploring to be done. And can you talk a little bit about Abilify with pregnancy and fetal effects?
Again, it's going to be another second-generation antipsychotic. I think if you're thinking of Abilify, I would go to mother to baby and grab that fact sheet, but it hasn't been associated with any major adverse pregnancy outcome. And so overall, I think it would be that discussion of the risk versus benefits with the mom. Similar to the SSRIs, there are some concerns about some withdrawal side effects with the second generation antipsychotics. But they, as long as at delivery, they know that the infant's been exposed to medications, I think that's the most important piece, is that communication that baby has been exposed to medication, so they may just need to be monitored. And overall, it does pass into the breast milk, but seems to be compatible with breast milk.
Okay. And I wanted to just update both you, Bridget, and our audience. It sounds like there's a glitch that's preventing both of our presenters from being on at the same time here today. So I don't believe Dr. Hecox is going to be able to join us for the rest of the chat that we have here. So Bridget, you might be flying solo. Unless a miraculous occurrence occurs, but that's the thing is there's always new technology coming out, and this is a brand new version of Teams that we're rolling with here for this webcast. So we thought we were being very innovative, but we're still discovering some of the things that do work one way versus another. So we're pioneers together, friends, as we very often are in the realm of healthcare in the state of Oregon. But we'll still do our best to try to answer as many questions as we can. Do you know this question? I don't know how much you've been exposed to this, but are there more efforts currently underway in the state to increase access to methadone that you've heard of?
I'm not aware of anything at the state. I know nationally there are efforts to increase access to methadone and buprenorphine, but I don't know if there's specific state issues.
It was both fascinating and incredibly disturbing to hear people, echoing the observation that, they're seeing this, huge increase in fentanyl, and that it's like heroin's disappearing, in terms of usage now, and that it's fentanyl's just going through the roof. I mean, you had other experiences seeing that you wanted to comment on?
Similar to Kerri, just seeing that for substance use, it's more difficult to get patients on the medication to prevent the withdrawals with fentanyl. So you see really low dose initiations so that they're not going through precipitated withdrawal because of the high dose fentanyl.
Okay, excellent. I'm just checking out some more questions here. I want to make sure that I try to get everything that I can here. So multitasking all over the place. A lot of folks, I think, had some questions about Eat, Sleep, and Console being implemented, and I know there's a few people on the chat here today that are implementing that themselves. What other things do you think are worth emphasizing about that program?
Yeah, I was not aware of that, so I would be interested if Kerri was able to come. So I would be interested if Oregon was implementing that approach rather than the medication approach.
Yeah, it sounds like some are. So we're going to have to dive into that. And what I'm going to try to do, attendees, is when we send out our slides and follow-up information for you, we'll see if we can't put together more of a fact sheet as well for you and try to see if we can locate some other hospital resources that have those programs in place.